And this never would have happened if it wasn't for the fact that we have valued retired faculty and staff at USC, at the Emeriti Center, who constantly contribute. Every single year, the USC Emeriti Center changes based upon the wisdom, knowledge, and experience of our USC retirees. So we were established in 1978 through the Provost's office, so we've been here a long, long time, and we service our USC retirees and pre-retirees, but we have programs for the entire Trojan family, our alumni, and our outlying community. So this is a very valuable event for everyone. I'd like to specifically thank Marilee Potoff from the House Research Institute for helping to put this together, and for John Orr, who is responsible for getting us interested in all kinds of important technologies for hearing, and also Kathy Hammonds from the Disability Services and Programs. And so now I would like to start off with our wonderful partner and dean of the school, the Davis School of Gerontology, Dr. Hassi Cohen. He is the dean, and he's a preeminent researcher in the field of gerontology. He is the holder of the dean's chair and executive director of this Andrus Gerontology Center. He has a number of accolades that I could be talking about, but since we don't have that much time, I will call him up to the podium and let him tell you a little bit about his research before we kick off all of our panels. Hassi.
Thank you. Thank you, Janette. And on behalf of the USC Davis School of Gerontology, and in partnership with the USC Emeriti Center, I'd like to welcome everybody to today's event, which I really think is a tremendous opportunity to have all of you engaged in this incredibly important topic. And since I became dean of the Davis School, I've been thinking a lot about something that I call the spans. And foreign policy experts talk about the stands: Afghanistan, Pakistan, Kyrgyzstan, which is in the news today. And we gerontologists talk about the spans: lifespan, health span, wealth span. And I'd like to coin a new term today, which is hearing span. And I think when we deal with the fact that medical science has been so successful over the last century in nearly doubling life expectancy for the American population, we have to think about this in the context of the fact that hearing disorders are dramatically increased as a function of age. And hearing loss is, in a sense, an age-related disease and an important manifestation of impaired health span. And this is something that we have to be addressing more closely in the gerontology community. And just a word, you're not going to hear about my research today, only to say that we are interested in our laboratories here in how hearing works, and particularly in an area that we have been making important contributions to, which is mitochondrial biology. The mitochondria is the energy center of the cell, and different organs have different mitochondria, and there is what's considered a rare disorder, which is maternally inherited hearing loss, which is a result of a mitochondrial problem. But it appears that the mitochondria, as a result of continuous lifelong stress, is involved in a lot of aging-related diseases and may very well have a role in aging-related hearing loss. And we hope that our work will create potential diagnostic or even therapeutic benefits to people with hearing loss. And I'm looking forward to a partnership with those scientists, some of whom you'll hear today, who are involved in this area. And finally, our interest in the Davis School in the hearing loss issues spans all aspects of gerontological research and care. Dr. Hagedorn is going to be speaking to you later on about some technological aspects of solutions to hearing loss. And that is an important area for me to integrate into one of the initiatives I think are critical to the future of gerontology, which I call the Digital Aging Center at the USC Davis School. And I hope we'll have an opportunity to develop a partnership with all of you around further work in that arena. And one last thing is one of our benefactor, Mary Lou Doré, has come up with an idea that she is very connected to the hearing loss community and proposed this little pin, diagram of which shown here, and we'll have a booth over lunch showing more details about this, a pin that will communicate elegantly to other people about concerns about hearing that people can wear. And she is promoting this. It's a nonprofit mini enterprise. And if anybody has interest in this, you can hear more over lunch. Thank you all for coming. I hope you're going to have a wonderful time today. And thank you, Janette, for your leadership and organization for this event.
Thank you, Halsey. And now I'd like to introduce James Boswell. He's been in executive management for over 30 years and has experience in administration, industrial relations, human resources, community relations, public relations, and research administration. He joined the House Research Institute as Chief Executive Officer in 1991 and worked closely with management to develop a new strategy to expand the Institute's research directions. The House Research Institute has a worldwide reputation as the leading independent research and education institution devoted to hearing loss and related disorders. Mr. Boswell's leadership has ensured its place on the cutting edge of hearing science in a changing field. Jim holds a doctorate degree in organizational development from Madison University and earned his master's degree in industrial psychology from the University of Tulsa, which honored him with its Distinguished Alumnus Award. A native of Oklahoma, Jim now lives in Pasadena, California, with his wife Pam, who is also a graduate of the University of Tulsa. Please join me in welcoming Mr. James Boswell.
Well, Janette, thank you very much. That's a very, very kind and probably undeserved introduction, but I appreciate it. And if you want to say some more, it'd be fine, too. Can you hear me okay in the back? Dean Cohen, you left out one span that's very important to me and maybe others, and that's the waist span. All worried about. Well, we're just, I can speak on behalf of my distinguished colleagues that we're just very, very pleased and honored to be part of this. And Janette, we want to thank you and the Emeriti Center for establishing this, and of course our own Marilee Price for working so hard. Now, there are two things that probably you weren't aware of that I need to tell you right up front, just full disclosure. There will be a test following this, so be sure to pay a lot of attention. And the takeaway you're going to have, the value you're going to have, you're going to take away in the next 2 hours the knowledge that it took our distinguished panelists 4 years of medical school, 4 years and 2 years of fellowship, and 4 years of graduate school. So you're going to have a medical education, no more of hearing health in 2 hours than it took combined 8, 10 years. So that's a carry-away, a plus that perhaps you weren't aware of. Well, let's get started. Janette, thank you very much for the words about the House Research Institute. We've been in business since 1946, founded by Dr. Howard House, and the mission has remained the same. and that's simply to develop knowledge and share it. We do that through scientific discovery, we do that for sharing our information, and we do that with clinical care. We are what we are primarily because of our sister relationship with the House Ear Clinic. Simply said, a worldwide reputation for being the finest group of physicians caring for problems with hearing and related disorders. And you're going to meet three of their very distinguished physicians and audiologists. So let's get started with that, and let's begin by introducing our first speaker. We're going to really cover three topics, and that is how we listen and the various types of hearing loss. And we're going to talk about causes of hearing loss and what kind of treatment is available for that. And then the third, we're going to look at hearing aids and how hearing aids are used in the treatment of hearing loss. So let's begin, and let's begin by our first panelist, practicing surgeon, otologist with the House Clinic, and he's also president of the House Research Institute, which was founded, as I mentioned earlier, by his late father, Dr. Howard House, a legend in the medical field and especially on your campus of the USC. Now, I don't think he's wearing the school colors today, but he does have the pin on. And John is a distinguished graduate with a bachelor's degree from the University of Southern California, then went on to receive his doctorate in medicine from what is now called the Keck School of Medicine at USC, and completed his otolaryngology, which is ear, nose, and throat for us in the lay world, as a resident at the Los Angeles County USC Medical Center in 1974. And John did that after a 2-year tour of duty in the U.S. Army. He served as chief of the ENT branch at Beach Army Hospital in his favorite city in the whole world, Fort Walters, Texas, right? He has a lot of stories about that, as you can imagine. John's been in private practice as a neurotologist at the House Clinic since 1975. Dr. John House. Dr. House to please start off with telling us a little bit about the amazing process, and it is an amazing process, you're going to be fascinated, of how we hear and the various forms of hearing loss.
Thank you very much, Jim. It is an honor for us to be here. We really enjoy, of course, I enjoy coming down to my alma mater. By the way, you didn't mention I was also on the swim team here, and we won the national championships when I was there. So we were, I think, 4th place this year, which I was thrilled to see. By the way, Jim, it wasn't Fort Walters, Texas. That was the name of the fort. We were in Mineral Wells, Texas. That's not too far from Jacksboro. It's like twice the population. I think we called it Miserable Wells. Okay, now I need to figure out how to get my presentation up here. Anybody know? Let's see. Okay, here we go. Okay, I'm sorry. We're going to get organized now. Was a pointer and an advancer? Here it is. Okay. So I'm going to be talking to you a little bit about hearing loss and some of the causes, a little bit more about the anatomy and the causes and the types of hearing loss and the incidence of hearing loss. Hearing loss does affect many more people than most diseases put together. In fact, as it was pointed out, with age, we do tend to find hearing loss becomes much more prevalent. As has been mentioned, we are from the House Institute and the House Clinic. The House Clinic is separate. That's our private practice. This is our research facility, and our clinical practice is located just up the street at 3rd and Alvarado. This is a statue that one of our patients made when we built the building. That's a statue of Howard House, which is kind of neat, but a little bit artistic. But people do get us confused because you hear about the House Clinic and so on, but some people don't confuse us with the House of Hearing. And, people write to us, and sometimes they get a little confused, like the Horse Ear Clinic or the Mouse Clinic. By the way, Mouse was my nickname when I was on the swim team. John House from the House Air Clinic. And of course, here's my favorite one, is the House Rear Clinic. I think someone got the ends mixed up. But let's talk a little bit about the anatomy of the ear. As has been mentioned by Jim, I have been involved in this field ever since I finished my medical school training here at USC in 1967. I love what I do, and I love the ear. The ear is a very complex structure. There are many things that go through the ear that we don't realize. It's responsible for hearing, which of course we're all here to talk about. Also, another part of the ear is related to balance. So this area here is called the inner ear. So here's the cochlea, and it looks just like that pin. It looks a little bit like a snail shell. Here's the balance canals, and these are called semicircular canals, and they help us to maintain our balance. This is the outer ear, and this is the middle ear. So sound is transmitted through the ear canal, and the eardrum vibrates in response to changes in pressure. So hearing is actually just changes in the atmospheric pressure. And in fact, the eardrum is so sensitive that about 0.00 dynes per square centimeter will cause us to have a sensation of hearing. And I think that's just a little tiny bit of movement. About the movement of a hydrogen atom will be enough to cause us to hear. Obviously, as we develop a hearing loss, it's going to take a little bit more than that. And then attached to the eardrum are the little ear bones. We have the three little ossicles, we call them, the malleus, the incus, and the stapes. Now, many people call those the hammer, anvil, and stirrup. And the stirrup does, in fact, look like a stirrup on a horse. And as the stirrup is vibrating, it's causing fluid waves then to travel up through the cochlea and stimulate 15,000 little delicate nerve receptors. And when those little nerve receptors are stimulated, they will send a nerve impulse then along the brain where it has to be interpreted as sound. The higher frequencies are picked up here. So this is like the keys on the piano. As the sound comes in, if it's a high frequency, it's these hair cells here that will respond. If it's a low frequency sound, it's these hair cells that will respond. So when we talk about hearing loss, we're talking about anything that interferes with the transmission of the sound, the vibration, or the nerve impulse to the brain. So this would be, when your physician looks at your ear, this is what you see. This is a normal tympanic membrane. And I again, enjoy this because there are so many things that one can see if we have a translucent eardrum like this patient. So here's the malleus, the first ear bone, which is attached to the eardrum. You can actually see a little shadow of the second ear bone right in here. Now, if a person loses their eardrum, before I do that, these are the little ear bones, and you can compare them then to, for instance, to a dime or to a match. The ear bone, the stapes, is the smallest bone in the body. Now, one of the conditions that you'll hear about is if something happens to this little ear bone and it doesn't vibrate properly, we replace it with this little wire right here, which is done as an operation, and I think Dr. Goddard will be talking a little bit about that. Now, this patient here had lost their eardrum due to infection, and that's one of the causes of hearing loss. If you have infections and it causes damage to either the eardrum or the little ear bones, then we may see the patient then will develop a hearing loss. So you can see, again, here's the malleus, the incus, here's part of the stapes. Attached to the stapes is a little tendon, which we call the stapedial tendon. When you're exposed to loud noise, that contracts in order to try to protect your inner ear. Now, unfortunately, it's not particularly effective because we've managed to make lots of loud noises that we can overcome that. This is actually the inner ear, so you're actually seeing the outside of the inner ear. This is a little window here which helps to, as this bone vibrates, this little window also has to move to allow the fluids to move in the ear. There's a little nerve that runs along here. That little nerve provides us for salivation. Isn't that interesting that we have that in the middle of the ear? We also have a nerve up here which helps us with taste. There's also another nerve right here which is called the facial nerve. That nerve moves your face. So when we're operating on the ear, we've got a lot of things to look out for. Have to be very careful. So we talk about hearing loss, the various types of hearing loss. One is conductive. Remember I mentioned to you that if we have a large hole in the eardrum or we have damage to the little ear bones, a person may, in fact, then begin to lose their hearing, and that's because the sound is not conducted to the inner ear. Anybody here know what the most common cause of conductive hearing loss is? No, that's explosion. No, that would be the nerve. We'll get to that one. No, it's wax, by the way. And I don't recommend that you use Q-tips. The next most common cause of progressive conductive hearing loss in adults is a condition called otosclerosis, and that is a hereditary condition, and I think you're going to talk a little bit about that. But that's when that little ear bone doesn't vibrate properly, and that starts in the 20s and then progresses as people get older to cause a progressive conductive hearing loss. So anything then that blocks the transmission of the sound, so again, the ear canal filled with wax, a perforation or hole in the eardrum, damage to the little ossicles or ear bones, would all cause a conductive hearing loss. In children, we see fluid in the middle ear. I'm sure some of you have had children or grandchildren that have had this problem with fluid in the ear, and they do tend to lose some hearing. Fortunately, that's temporary. Usually it clears up on its own. If it doesn't, then the patient can have little ventilation tubes inserted. So the next type of hearing loss is called sensory neural, and that's basically a problem anywhere in the inner ear or along the hearing nerve. Again, okay, what's the most common cause of that? Well, noise, loud noise, and age. So the age we call presbycusis, and that's the type of age-related hearing loss which comes on and sometimes as young as in the 50s, and sometimes people don't have it. My father, who we mentioned earlier, was 95 years old when he passed away, and he did not have any hearing loss. And we do know, by the way, that there is genetic factors in that. So I'm happy to say that I think I've inherited some good genes there. So that would be then a sensory neural hearing loss. And we mentioned age, and we also mentioned noise exposure. Unfortunately, with the situation in Boston we just heard about, I'm sure many of those people will, in fact, have experienced some permanent hearing loss due to that explosion. We see it a lot now with these poor kids coming back from Afghanistan and Iraq, and I saw it when I was in the Army from the kids coming back from Vietnam, losing hearing from their exposure to loud noise. In fact, that's the most common, or the most money that VA spends over the years has been with hearing loss, because that's very common among soldiers. Now today, of course, we see it now with young kids with rock concerts, turning up their iPods or iPads or iPods to the max, and in fact then losing hearing. So we have to educate them, and that's one of the things that we're doing at the House Research Institute, is we have a program to educate young people on the effects of loud noise. And then the next type of hearing loss then would be a combination. Obviously, if someone has a hole in the eardrum and they have age-related hearing loss, we call that then a mixed loss. So now this is a picture of the cochlea. It's been sliced. It has 2.5 turns. So again, it looks like that snail shell. We have the area right in here. There are these are where these little hair cells are, we call them. So as the fluid flows through these chambers, it causes movement of this membrane, which then causes a stimulation of the nerve to send that impulse along the nerve and then along the hearing nerve to the brain. So it's a phenomenal structure. And this is what the little nerve endings look like. Again, this is that area that I was pointing to, the organ of corti. This is where the little hair cells are located. And we have 3 rows of hair cells called outer hair cells and 1 row of inner hair cells. And when they get damaged, they look like this. And so this is one of our frustrations. You're born with your complement of hair cells. When or if you lose those hair cells, they do not regrow. Now, part of our research, in fact, we just had a lecture this morning from one of our researchers on working on regenerating these little hair cells. Chickens do it. You can knock off the chicken hair cells, and 2 weeks later they've grown back. Humans don't. We're working now with rats getting them to regenerate the hair cells. Hopefully one day we'll move up to the humans. But it's not easy. So I'm going to play you a little video. This is fun. And this is going to show you, the problem with nerve-type hearing loss is not necessarily the hearing, it's the understanding. And I hear this all the time. You know, I can hear, but I just don't understand. Because the big reason is that we lose the higher frequencies. On that graph that he showed, you could see how the high frequencies were dropping off. And the high frequencies are responsible for the consonant sounds. So what people will say is heat or eat, or pen or tin, so on. I had a patient come in that was telling me that she ordered a roll in a cafeteria, and the person behind the counter asked her whether he wanted, do you want me to heat that for you? And she says, no, I'll eat it. One more. I hear this all the time, but I always get a kick out of some of them. Talking to a travel agent about the accommodations in the hotel, and she said, would you like a queen bed? And he said, of course I want a clean bed. So this is going to play a little bit of a little cartoon. Oops, that's just, sorry, I got ahead of myself. This shows the incidence. Again, I talked to you a little bit about that with age, and you can see that as people's age increases, you can see that we have a greater percentage of patients with hearing loss. You'll notice that women tend not to have as much hearing loss as men. And that's why, invariably, I ask the man, so what brought you in today? And he says, my wife. Occasionally it happens the other way. I'll tell you the worst thing that happens is that when someone comes in and says, my wife says I can't hear, you know, she's just always on me, and so I'm coming in here to find out what I can do about it. The worst thing is I found out they have normal hearing. And then they have to go back. So they say, aha! He's ignoring me. But you know, there's another thing on the slide. It does say that, you know, for instance, blacks have less hearing loss than Caucasians. And that's because we do know that age-related hearing loss is hereditary. One of our researchers, Dr. Friedman, has identified a gene that's responsible for the deterioration of hearing. So it does tend to run in families. Okay, so now I'm going to play you the video.
1, 2, 3, 4, 5, 6, 7. Aha! You're on my apartment building on Granite Avenue. You owe me $300.
Normal hearing.
Fred, take it easy. It's only a game.
Well, I'm just like them big tycoons. I play to win.
It's hard to lip read them. So you can hear them fine, right? Anyway, so that's what happens, and that just a kind of a demonstration. So it's very important when communicating with people with hearing loss is to get their attention, look at them, and then speak in a normal tone and not fast. The kids, by the way, speak fast. I don't know if you have any grandchildren like mine. Blah, 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 blah. It's hard for me to understand them, but it's important that you get their attention, look at them, and modulate your voice. That really helps. So I think next, I will introduce the next one, or you? You will. Okay, you're up. So thank you very much. We'll have a little panel later.
We'll have an opportunity to take some questions after all three presentations. What Dr. House didn't tell you, and he should have, beside the fact he was captain of the swim team, he had a patient come in about 4 weeks ago, and I was reminded of this when he said the spouse is normally the person of first recognition of, or at least suggesting a hearing loss. And Dr. House at the end of the examination said, well, when you go home tonight, your wife in this case is cooking dinner, stand behind her at the door and say, what are we having for dinner? And if there's no response, get a little closer and say, what are we having for dinner? And then stand about 3 feet behind her and say, what are we having for dinner? So he did. First, standing at the door, no response. Got a little closer. What are we having for? No response. Got a little closer and said, what are we having for dinner? And she turned around. For the third time, we're having roast beef. If we have time, I'm going to ask Dr. House to tell you about his experience fitting hearing aids with President Reagan. It's a wonderful story. Well, our next presenter is a physician in private practice at the House Clinic. He recently joined the clinic in 2012, just a year ago, shortly after completing his neurotology fellowship there. He received his bachelor's degree from the University of Virginia, doctorate of medicine from Virginia Commonwealth University in Richmond, Virginia, and completed his residency. Now he moved out of the state of Virginia to go to the Medical University of South Carolina. Please give me a warm welcome for Dr. John Goddard. John, now that we've heard Dr. House talk about the different types of hearing loss, please tell us a bit about the common causes of hearing loss and what we can do about it.
Very good. Thank you, Jim, and thank you to everyone for coming and for letting me participate in this great symposium. I'll pull up my slides here. Okay, so Dr. House did a great job introducing what types of hearing loss there are, and I'm going to talk a little bit about what causes them, what are the specific causes, and how do we treat those. So just to sort of refresh on what he said, we're really going to focus on the conductive and sensory neural hearing losses. The combination, again, of those two we call a mixed hearing loss, but usually what I'm talking about will fall into one of those first and third categories. So as he mentioned, and again, there's going to be a test, so we're reviewing here, but wax impaction is a very common cause of hearing loss. Why do people get wax impactions? Well, we all make wax, and that's actually normal. We should all have wax. It's protective. There are some features of wax that do protect the ear canal. But, as everybody knows, Q-tips have been around a while, and everybody thinks they're used to clean out the ears. But actually, if you read on the box, it says not for use in the ear. So there is a reason for that. But putting Q-tips and other objects in the ear can actually prevent the wax from coming out, which it should do on its own. Some people have trouble with wax buildup, and they have to come and see myself or Dr. House or people like us to help clean out the ears. And so I'm going to have a few pictures in here, so just to keep it interesting. But so this is a picture of the ear canal, and it shows just a block of wax. And you can imagine that the sound will not get through that wax very easily, and that's, like Dr. House alluded to, a cause of hearing loss. But thankfully one that's very treatable. People may have heard of things like softeners, putting rinses in, candling. Have you maybe heard of where people stick a candle in the ear and try to suck out the wax? Not a good idea. So all of these things, are out there on the market, but frankly, we see more problems with them than we do good, because we see a lot of people hurt themselves when they do those things, and then we have to go back and try to help it and fix it. But in general, what we do is we use specialized instruments and fine tools with a microscope to allow us to see things well and clean that wax out, but that can be very effective. Now, one of the most common causes of hearing loss, as Dr. House also alluded to, is something called otosclerosis. And I would venture that there's several people in this room who may have this problem, because if you have hearing loss, because it's a very common problem that is progressive. It has to do with those hearing bones, as Dr. House said. So there's 3 hearing bones, and that third one is the stirrup bone. It becomes fixed. It doesn't move. And when you don't have it move, it doesn't vibrate and move those fluids in the inner ear. Now, when you look in someone's ear with otosclerosis, everything may look just fine. But between hearing tests and what we call tuning forks, which are a simple form of a hearing test, we can identify those patients. But again, it's this lack of movement that leads to the hearing loss. So how do we treat that? Well, it's not a deadly disease in any way, which is good. So some people just tend to observe it depending upon their age and how severe their hearing loss is. Hearing aids are a very effective means of overcoming the hearing loss that's associated with this problem. And our next speaker, Monica, will talk a lot about that. Again, sorry, we didn't get together on this, but I had a similar picture as Dr. House, and that's a dime, and you can see the size of the stapes bone. And really the third option that we are able to do is we're able to do surgery on that bone to remove it and replace it with these type of prostheses. This is actually an older style prosthesis, but they're made of titanium and various metals now. And we're able to replace that bone and allow us to bypass that blockage problem and improve the hearing. And it's a very successful operation. Frankly, Dr. House has been well versed in this, and his dad really helped pioneered this surgery at the House Clinic. And this just shows just a schematic, again, of that. We take out that bone, and then we actually put in a fake bone or a prosthetic bone to bypass the blockage problem so we can talk to the inner ear and allow the transmission to occur. So what else? We talked a little bit about, or Dr. House talked about, fluid in the ears. Not only children can have this problem, and some of you may have been on a flight or had a cold and you feel like your ear gets blocked up afterwards. Well, it's not uncommon that we can see fluid in the ear after something like that, a flu, a cold, an upper respiratory infection of some sort. So this is, again, a picture of a normal eardrum. It looks nice and clear. When there's fluid in the ear, when we look at it, we see this yellowish hue. Sometimes it's different colors, but you see this sort of level of fluid that's sort of sitting in the ear, the space behind the eardrum. So how do we treat that? Well, sometimes we can give people antibiotics and sometimes a medication called steroids to help dry up the fluid and improve things. But a lot of times, and again, not just in children, but even in adults who are prone to this condition, we put in a little tube. So this is that tube. It's blue here, and they come in different colors and sizes, but we basically make a small incision and drain out that fluid and put this tube in to allow it to ventilate and clear out that fluid. And we do this right in the office most days, so it's a very common procedure, but it's very effective in helping overcome that hearing loss. So what else do we see that can cause hearing loss and that we can treat in various ways? Well, again, as Dr. House alluded to, a hole in the eardrum can occur from a variety of things. Blast injuries, as somebody mentioned, that actually can cause a hole in the eardrum in addition to nerve loss. But more commonly, it's infections. When people have chronic infections, they can develop a hole in the eardrum. And you can also develop, with these chronic infections, a disconnect between the hearing bones. Much like in the case of otosclerosis, if there's not an ability to transmit the sound to the inner ear, a hearing loss will ensue. And so if those bones are not connected, then you won't have an ability to hear very well. And finally, there's some unusual cases of skin cyst formation. We call that cholesteatoma. That can also lead to damage of the hearing bones in the eardrum, thus affecting the hearing. So this is just a simple schematic of how we might fix a hole in the eardrum. This is something that Dr. House and myself do fairly routinely. And so again, you have a hole, and what we do is we borrow some tissue from behind the ear, and we use that to cover up that hole and have actually the skin of the eardrum, because there's skin that lines the eardrum, grow over that hole. And that can be very effective at closing any size or type of hole in the eardrum and restore hearing. Now this is a schematic of a case that we're seeing not uncommonly. We have a fairly new technique where basically you see that these are those three hearing bones, again, the first, the second, and the third, but they're not connected. And that would lead to a significant hearing loss, and that can develop again from chronic infections. And so what we are able to do now, sometimes we have to use, again, a prosthetic device, but in some cases we can use a little bit of cement. So we're borrowing from the construction world, and we use a little special type of cement to reconnect those bones. But doing that will make a huge difference for someone with this problem, because it'll reestablish that connection and allow them to hear through their hearing bones. And finally, this is that condition I mentioned, and this is just showing the ear. This is a condition that we sometimes see people of all ages where they have this skin trapped inside the ear and behind the ear in this place called the mastoid bone, which is just the bone that you all feel when you touch behind your ear. That's called the mastoid. And in this condition, it can lead to hearing loss and other problems, and we have to treat this surgically to fix it. And ultimately, a lot of times people end up losing part of their hearing bones from this process. So we have to reconnect those bones to, again, reestablish hearing. So this is just another schematic of the ear. You're getting to see a lot of pictures of the ear, but these are different types of what we call prostheses, or artificial hearing bones. And again, you see the first bone and then part of the second, and then we have this metal or titanium prosthesis that connects these two. That's kind of like what we did with the cement. Sometimes if the hearing bones are gone, except for the third one, we use a different type of prosthesis. And again, we're connecting the eardrum back to the hearing bones so that we can reestablish the connection to the inner ear so we can hear properly. So those are some of the big conductive types of hearing losses that we see. And we also see a lot of sensory neural hearing loss. And this list could be to the floor and longer. but I wanted to keep it, as simple as possible. But there are a lot of causes of sensory neural hearing loss. Genetic causes, as Dr. House alluded to, are very common, not just as we age, but also as children are born, they may be born with a genetic hearing loss. We talked a little bit about infection. That can also cause problems with the nerve. Traumatic, we talked a little bit about noise exposure. Surgery itself can sometimes cause nerve damage. Medications is a big one. I mean, there are certain antibiotics that are given when people have infections in the hospital that can lead to nerve damage. And that's important to know, and it's important to find out early. There are other medications. Vicodin has been associated with hearing loss and a progressive hearing loss, and you may have heard of that in the news, and that's something that we counsel our patients about, especially those who take pain medications for various ailments and illnesses. And of course, age-related hearing loss is a big one, and that's why we're here today, but it's a very common cause of this nerve damage over time. There's some other rarer causes that, again, we see. So we have to sort of go through all of these things when we're looking at our patients and talking to them to figure out what is the cause and how do we treat it. So, again, we didn't get together on this, but this is a very good depiction of those little hair cells again. And we have this up in the office because I think it illustrates a good point. Again, it shows what things look like when the hearing cells or hair cells are working well, but when they're not, we lose them, and that's what leads to this problem that we see in our patients, particularly as aging occurs, and that they're unable to hear well. Now, there are some medical and non-medical, non-surgical treatment options that we have for different types of hearing loss, and so depending upon the cause, sometimes medication can be helpful. For example, in a patient who has an autoimmune where the body is attacking the ear, we sometimes think that steroids and other medications can be helpful to prevent that progression. So I want everybody to come away that there are different ways to treat things, surgery being one of them, but medications and other devices being other options as well. So this is just a quick slide on a surgical device that is basically a surgically implanted hearing aid. It has two parts, and it's used for people who have sensory neural hearing loss. But basically, you implant a magnet in the ear, and it sits on those little hearing bones. So this is for someone who has normal hearing bones, but the nerve is not working well, and they're having trouble with hearing aids. And we'll talk about hearing aids, and frankly, for a lot of our patients, thankfully, hearing aids that are properly fitted will be very, very effective in helping their hearing. But in cases where we're not able to do that, these other devices come into play. But again, this device called the Maxim uses a magnet and then a small type of hearing aid. It's really electromagnetic, so it's different than typical hearing aids, which you'll hear from Monica about. But it drives this little magnet to move and increase the vibration and strength so that you can hear better. Now, there's another condition that some people have where they have a deafness on one side. So if you had hearing loss on one side and that cochlea is damaged, for example, the hearing nerve is damaged on that side, we can take this special device, which is attached to a small post behind the ear, and that's just a post behind someone's ear, and this device transmits the sound through the bone to the good ear. And that's, again, a condition called single-sided deafness that we're still working on how to treat best, but these are some of the options that we have available. And then I think important to point out is another condition that we see a lot of, and that is basically as people age or as people's hearing loss gets worse, we see a severe hearing loss to profound hearing loss in some people. And that just basically means that they're at the bottom of this audiogram scale that Dr. Cohen showed earlier. So very, very poor hearing, very much difficulty hearing in any situation, let alone understanding words. And in these cases, we do have a solution, and it's called a cochlear implant, which Dr. Bill House, who is Dr. Howard House's half-brother and helped develop this technology, is responsible for really promoting across the world. This is an example of a cochlear implant, what it looks like. And this is the device, and what it does is basically we place this wire electrode into the cochlea, into those turns that Dr. House outlined, and we're electrically stimulating the inner ear to try and restore the hearing. And it's an amazing device. We're using it more and more, and I think the reasons for using it will increase as time goes on, so that we can hopefully get to those people who are still struggling with their hearing loss and maybe haven't been able to use a hearing aid as effectively. So this is a device that I think you'll hear more and more about as time goes on. But again, I think as a lead into the next speaker, it's very important to understand that many people, and I would say most people with sensorineural hearing loss, can be helped in many ways by using a hearing aid that's properly fitted. And so that's what we're going to talk about next, and I guess I'll let Jim introduce Monica. Thank you.
We'll have an opportunity to ask our panelists later questions, and just a tee-up type question that I think we should all be aware of. What can we do to prevent, or what can we do on a positive side to encourage healthy hearing? So keep that in mind as we do. And okay, here's your test question, one of them. And let's just start with a show of hands. If you, just theoretically, if you had both a hearing loss, profound hearing loss, you're deaf, and you're also blind, and you had one opportunity to restore one of those senses. You're blind, you're deaf. Which one would you restore? Oh, good. Gosh, you took the rest of my thing away, but absolutely, and I was so amazed, because typically I would think people would shout out vision, ability to see. But Helen Keller, a name we're all familiar with, when asked that question in a very profound way, said she would restore hearing because it is a contact with other people and the human part of the person. So it's an interesting, and good for you that you were right on top of it. Now, our next speaker received her bachelor's and master's degree from in audiology now from the University of Wisconsin in Madison, and her doctor of audiology from the Arizona School of Health Sciences. She's a member of both the American Academy of Audiology and the American Speech Language Hearing Association. Her practice focuses mostly on hearing aids. She worked at the House Clinic now for the past 3 years and is director of audiology. I know the House physicians and certainly the House Research Institute feel we're just very gifted to have a person of her remarkable skills. So it's my pleasure now to introduce you to Dr. Monica Andriacchi. Dr. Andriacchi.
Thank you, Jim, even though you slaughtered my last name. That was pretty good. And thank you all for coming. Good morning. I am going to be talking to you about hearing aids, as you can see. And I'm going to use the right button here. There we go. So today, I know, my husband's a historian. He found that for me. So just a quick outline of what I'll cover. I'll give you a little bit of general information. We'll be talking about the sizes and styles that are available, some of the advanced features and technology levels, accessories that are becoming very common for hearing aids, and a little bit of what to expect when you are fit with hearing aids. So obviously this is another very funny picture. Thankfully, hearing aids have come a long way since this one in the previous slide. The first thing I'd like to say is that all hearing aids today are 100% digital. It's a common question I get in the clinic. There are no more analog hearing aids. Digital hearing aids simply means each one of them has a little miniature computer inside of it. What we do with that is we program the hearing aids specifically to each person's hearing loss. Actually, each ear is individually programmed, so it's a very precise prescription for you. And then after the prescription is put into the hearing aids, we can personalize it to each person's lifestyle by adding custom programs. Like if patients like to go to Disney Music Hall, we could put a music program which will enhance the music experience. Or if people like to come to lectures like this today, we could put in a lecture program that will better enhance this type of environment. This is a picture, just a quick overview picture of some of the styles and sizes of hearing aids today, and I'll briefly talk about each one. I'm sure all of you have seen this style hearing aid. It's called a behind-the-ear hearing aid. or BTE that we refer to. It's used with a custom-made ear mold that's shaped to the ear when it's connected with a little tube. Today, although it's not the most common style hearing aid, it is still used for people who have a severe to profound hearing loss. It's got the power that they will need. And the biggest misconception that I hear about with this particular style is people think it's an old-fashioned hearing aid or with bad technology, and that's not at all true. It has the capability of having the exact same computer chip as any of the smaller ones, and it's very state-of-the-art. So it's just bigger and more powerful for those people who need it. But then, if you compare that to the picture here, this is a micro BTE, or behind-the-ear hearing aid. So they're made very small today. A common acronym is called a RIC, R-I-C. It stands for receiver in the canal. And as you can probably see at the very tip, there's a little rubber dome that is protecting the speaker or the receiver, which is sitting down inside of the person's ear canal. And this is the most popular style hearing aid that we fit in the clinic. At least 75% of the patients wear it. And the reason it's so popular is because it has many advantages. The one, because the receiver is sitting down into the ear canal, the increased clarity of speech is because it's sitting right next to the eardrum. It provides the most natural sound quality, and the reason for that is because the ear canal is not plugged up, as you can see from the picture. It's fairly open. Any residual hearing that you have is still used, and then the hearing aid, as I said before, is programmed specifically to just the area that you need it, so you get the best of both worlds, your natural hearing plus a little help from the hearing aid. It's very comfortable, and as you can see, again, there's very little material there in your ear. The back part is very lightweight, and it's so comfortable that people commonly jump in the shower with it, jump in the swimming pool. I had a lady who just recently went scuba diving, jumped into the ocean with her brand new hearing aids. And so that's a bad thing, I know, but they can be fixed. From a cosmetic standpoint, as you can see, it's nearly invisible. People hardly ever know that you're wearing this style hearing aid. In the past, when this style was first available, we could only fit it with people who had mild hearing problems. Today, they've made it so that we have 3 different strengths of receivers. The little wire you can see with the little rubber dome, we can just pull that out. Thanks. I don't know how to use that little put. Anyway, we can change it from a standard size receiver to a power to a super power. So we can fit most hearing losses with this type of behind-the-ear hearing aid. Not everybody, oh, that's right, I forgot about that slide. Everybody uses a dime, I guess, to compare size. But this is just a quick overview of how small they have become. I think behind-the-ear hearing aids, oftentimes people have a stigma against them. But they've changed, obviously, quite a bit over the past 30 years. In-the-ear hearing aids are still very common. This is it's called a full shell. They're made with, we take an ear impression so that they're custom made exactly to your ear. This is a larger size. It's typically probably the best used for people who might have manual dexterity problems or vision problems. It's easier to handle. They make one a little bit smaller, a little bit more cosmetically, maybe appealing to some people. They also have one that's called a completely in the canal. Not 100% invisible, but you know, it's hardly visible. And these 3 styles have been out in the industry for many, many years. But the newest one is called, and this has been about maybe a year and a half. This one has been on the market, or is called a completely or invisible in the canal hearing aid. And as you can see, it's still a custom-made hearing aid, so an ear impression would be required. It sits very deep into the ear canal, and it is 100% invisible. And I wrote on there, depending on the canal size, that is because if you do have a very tiny pediatric size ear canal, it will not fit like that. But most people with an average size ear canal, we could make that hearing aid fit deep inside of the ear. This is just a, well, you can see it's a comparison to the older style and then the new one, which is in black. The older one is in red, the newest one is in black. And a lot of patients who wear this style report getting much improved speech clarity or speech understanding because of how far it fits in and it's so close to the eardrum. So how are hearing aids like contact lenses? They're not like them, but the newest evolution in hearing aids was taken from the extended wear contact lens. And now we have extended wear hearing aids. This is becoming very popular. This is known as the Lyric. There's only one company that makes it. As you can see from the diagram, it's fitting in 100% invisible. What happens is an audiologist like myself will put the device in using a specialized tool, and we insert it deep inside of the ear canal. It goes about 4 millimeters from your eardrum, so it sits very close. It will stay in your ear canal 24 hours a day, 7 days a week, until the device dies. And that's an average of about 2 to 4 months. When the device dies, you take it out. You can discard it. We can take it out for you. It takes 5 minutes. We insert a new one, and then you're on your way. You can do all of your most daily activities, and including showering with it. So it's the only hearing aid that you can actually shower with. The Lyric has a very good fitting range. A lot of people feel they're not going to be a candidate to wear it, but we can fit people from mild to moderately severe hearing loss. What is the most important is, if you're considering the Lyric, is to have your ear doctor examine your ear. You want to be medically clear to make sure that there's none of the issues that Dr. House and Dr. Goddard talked about, to be able to wear it comfortably. It's going to have to stay in your ear for up to 4 months possibly, so you want to make sure that you don't have a potential for ear infection. If your ear is medically clear, then you would come to the audiologist. We have some measuring tools to make sure that the size of your ear canal will accommodate the Lyric. The Lyric comes in 6 different sizes, but we do have to make sure that each person has the proper length and circumference of their ear canal to wear it. Hearing aids, all hearing aids except for the Lyric, but all the other style of what we call daily wear hearing aids come in between 3 and 4 levels of technology. There's a basic level technology, which is great for people who are typically in quiet environments, maybe mostly have one-on-one conversations. A mid-level technology, more advanced, starts to introduce features that will help you in moderately noisy environments, maybe small group settings. And then the premier level is the most advanced. It usually accommodates people with a fairly active lifestyle, going from maybe a business meeting to a noisy lunch with friends, maybe going to the Dodger Stadium. All the kinds of activities, if you're fairly active, a premier level technology will be the best to accommodate it. And that's one of the things we use to help our patients determine what level of technology is best for them. So it's based on your lifestyle. Some of the advanced features that we're excited about in hearing aids, if the hearing aid is big enough, most of the behind-the-ear hearing aids and some of the in-the-ear hearing aids have dual microphones for noisy environments. Noisy environments are the most difficult for people who wear hearing aids. So the dual microphones, one microphone faces forward to try to pick up the speech that you're listening to. There's a back-facing microphone that's constantly surveying the background noise and reducing it, and they work independently of one another. Speech locator, again for noisy environments, the technology in hearing aids is so that it can actually recognize where the speech sound is coming from. Even if the person you're listening to is moving around, it's constantly looking for the speech sound and magnifying it a little louder than the noisy environment that you might be in. Inner ear communication means that the hearing aids now talk to each other, the right and the left. So what's really great is if you're sitting in a group and maybe somebody were to speak in on your left side, the speech information that goes into that left hearing aid is automatically routed over to the right ear as well. So you're hearing speech in stereo in both ears, which obviously improves your ability to understand. zoom control to focus on specific directions. You can push a button and tell the hearing aid which direction you want to focus on. Forward, but maybe you want to focus to the left or the right. We have patients who focus to the back. If they're driving a car and they maybe have children or grandchildren in the back seat, they want to hear them, you can say focus to the back. Autophone program for telephones. There's a program where you can bring the phone right up to your ear. The hearing aid will, in about 1 to 2 seconds, detect that there's a phone there, go into a specialized program for the telephone, and then once again take the sound that comes in from who's calling you and sends it over to the other ear as well. So again, you're hearing the phone conversation in stereo, and that's better than somebody with normal hearing. You know, we don't get to hear people with 2 ears. There's also tinnitus therapy. We haven't talked about tinnitus, but for people who have ringing or buzzing sounds in their ears, there are hearing aids that we can put a special program into them to help them with the ringing or buzzing in their ear. Here's just a picture of some various remote controls. These are becoming very popular because hearing aids are so small, they usually have very few buttons on them. This isn't allowing the person who's wearing them to adjust for volume up and down or to access some of those customized programs that I referred to before. The most exciting thing is the Bluetooth. Bluetooth allows patients to buy, these are just a picture of some of the accessories, there's many, but it allows people who wear hearing aids and have difficulty with a cell phone or television or even your home phone. You can buy one of these accessories and it's called pairing. You match it to your hearing aids and you will have a wireless transmission of sound directly into both ears. So you do not hold the phone to your ear, you just have the sound going directly into both ears. And with the television, it's people who are living with other people, they love it so they can turn the volume of the television down to 0 if they want to. But the person with the hearing aids can wear it and set their own independent volume because their hearing aids become a headset. So you don't have to wear a separate headset, you don't have to take your hearing aids out. Lastly, I'll just make a few points, which I talk about in the clinic every single day, about what to expect from hearing aids. First of all, they will not restore your hearing to normal. So if you have that expectation, please know they will not. There is an adaptation period. It takes a little while to get used to hearing sound again. A lot of people can get used to it within maybe 1 to 2 weeks. I like to say to people maybe 1 to 2 months, just so they're prepared. Most conversations will be made easier and you will not be asking to repeat nearly as much. Hearing in moderately noisy environments will definitely be improved. However, in a very noisy situation, a party, that type of event, you will probably have to make an adjustment on your hearing aid. That's where we could put in a special program. Hearing aids do not eliminate background noise. They only reduce background noise. Again, I say this at least 10 times a day. Initially, when you're fit with hearing aids, your own voice will sound different. Many people describe it like an echo. But after about 1 to 2 weeks, it will sound natural again. You should expect that your hearing aid should be comfortable enough to wear all day long, 12 to 16 hours. And very finally, something that shocks everybody if they don't wear hearing aids, you will be having to change batteries at least once a week. Batteries are not very expensive. Thank you.
Monica, thank you as well. We're going to take about 10 minutes and give you, our guest, an opportunity to ask questions. So I'll ask the panelists to come forward, please. I'm not sure. I'm going to bring the microphone around. If this microphone is working, is it?
They can turn it on.
Get on that side. There we go. I think that's working. No? Now it's working. While we're setting up, I'm just going to take an extra minute and ask Dr. House to share a wonderful story he had when he was fitting President Reagan with hearing aids.
Which story? I have a lot of stories. President Reagan was great. seeing him was a big thrill, and you can imagine we had to shut down the office and have bomb-sniffing dogs and all of that. But I think the story that was most fun is when I went back to the White House, one of my many visits, and I brought one of my sons. In fact, throughout the time I saw the president during his presidency, I had the opportunity to have my sons with me a few times, and he was very gracious. So we went to the Oval Office to make sure that his hearing aid would work with his telephone in the Oval Office, because it had one of these devices that allows you to use your phone. And my 14-year-old son was with us, and it was time for him to move to his next appointment. It became very obvious because his appointment secretary came in the back of the room and looked at his watch, and then he cleared his throat. And so Mr. President Reagan stood up and said, I have to move on to my next appointment. Whereupon my son said, Mr. President, I'm missing school today. Would you give me a note to give to my teachers? And yes, he did. And yes, my son still has the note. The teachers didn't get it.
We have the first question, and we'll try to work with both sides. I think we have a microphone and we'll just alternate. Sir.
Thank you. I have a question dealing with tinnitus, but also intermittent hearing return. I'll try to be very quick. Can I be heard?
Yeah, a little bit.
You have to hold it very close.
Hold it close. Do I need to hold it like this?
Yeah.
I'm sorry. Yeah. Excuse me. My personal issue is the following. It has to do with both tinnitus and intermittent hearing return. Very quickly, very tragic automobile accident about 40 years ago. I came out of the hospital, and about 3 days later,
Hold it closer.
Ring, ring, ring in one ear. Tinnitus. I said, okay, that's my life. I've got that for the rest of my life. About 20 years after that, I started noticing hearing loss. The reason being, I being an impatient person, if I'm on the phone and you get put on hold, then 20 minutes later somebody answers you, I decide, well, I might as well sit next to another phone. If that happens to me, then I can go left ear, right ear, two phones going at the same time. And the point is, I suddenly couldn't hear out of one of my two ears. That was the ear that had the tinnitus. So there's a trauma issue that I know must have accounted for the tinnitus, and therefore maybe for this eventual hearing loss. Now, the next issue is I was flying frequently across the country. That is nonstop. If I was on a nonstop transcontinental flight, landing on the East Coast, the plane comes down, Kawamo. I have full hearing. I hear the captain. I hear everybody announcing. I go in the hallways. I hear people talking. My hearing is restored. But by the time I get to baggage claim, I've quit paying attention to that. Well, I've got hearing. No, when I get to baggage claim, I no longer have my hearing. The point now being, why couldn't I just go to one of you people? I've done this many, many, many times. If hearing just comes to me naturally, should I just get a tire pump from my neighbor's kid? What do I need? What do I need to do? Is there a solution for this kind of trauma, or is it commonplace at all?
I'm going to give that to you, Dr. House.
Well, thank you. First of all, tinnitus is very common. 80% of our patients with hearing loss have tinnitus. And you can say tinnitus or tinnitus, tomato or tomato. It's all the same. So that's very common, and it does occur with various traumas, including neck injuries, head injuries, and, of course, hearing loss. What you're describing is a pressure change, and we do see that. The tympanic membrane, as I mentioned, is very sensitive to vibration, and it's common. I see patients, particularly those with high-frequency hearing loss, who clear their ears periodically because they can hear better for just a few seconds or minutes. And it's because you increase the tension on the eardrum, and it increases the high-frequency response. And it's just like a string on an instrument. And you tighten the string, you get a higher frequency.
My name is Sonia Rita, and I have a question about the connection between hearing loss and vertigo. Is there any connection between them? I have hearing loss, and also I had benign positional vertigo for about 2 years, and I wear hearing aids, and there is thought that there is maybe a connection between my hearing loss and the malpositioning of the crystals in the inner ear.
Very good question. As Dr. House alluded to earlier, the inner ear is connected, and there are two parts, the balance system and the hearing system. And there are actually various diseases that we really didn't talk about that link hearing loss and different types of vertigo. Now, what you're referring to as far as a positional vertigo, just to give some background, is when you roll over in bed or turn your head a certain way and you get dizzy or things spin briefly. We like to use the word vertigo and not dizziness because dizziness is sort of a vague term. But that's very common, number one, as is hearing loss. So frankly, the association between those two directly is very minimal. I think it's more commonly in the situation you're describing that these are just two common things that are occurring in tandem. An example of something that is more common but related would be something called Meniere's disease. So in Meniere's disease, people have hearing loss, tinnitus, pressure in the ears, and they get vertigo attacks that last minutes to hours. And those are all sort of together at the same time. But gradual hearing loss as we age and positional vertigo in and of themselves aren't directly related. Okay.
Second on this side, please. The gentleman right there.
I've had Meniere's disease for the last 12 years. Have there been any advances in Meniere's disease? And also, are there any bone conduction cell phones that I could place on my jaw to talk instead of in my ear?
I don't know about that.
Yeah, let me take the Meniere's. Yes, Meniere's is treatable, and it depends upon what the problem is. If it's severe vertigo, which is incapacitating, sometimes we'll do surgery to correct that problem. It doesn't necessarily help the hearing. So the hearing loss, which is typically fluctuating, good and bad, would be typical of Meniere's, and this could be sometimes treated medically and sometimes surgically also to stabilize the hearing. I'm going to ask Monica a question now that I have her, now that you brought that up, because that's, so you put a hearing aid in your ear, hearing aids, we always recommend two if the person has it, and you have the Bluetooth, so you have your phone sitting in your pocket, and your phone rings and your Bluetooth kicks in. Now, are you talking through your hearing aids?
Well, you know, the picture that had the accessory, so it's actually not hearing aids themselves that are matched to the phone. It's the accessory. So imagine you might want to, if you're driving, put the little thing that looks like a remote around your neck, or if you're sitting at a table like this, you could put it right here. But the phone is then matched to that. You have to speak into the microphone of the accessory. Okay. The caller's voice is what's going into both of your hearing aids. The phone could be essentially 30 feet away, as long as the accessory is close to you and your hearing aids.
And as far as the bone conduction cell phone, I'm not aware of anything quite like that. I've heard stories of children, for example, who have a conductive loss, for example, would put their teeth on the TV stand and they can hear through their teeth much better. Now there's a new device that I didn't really talk about that I showed a picture of that is a bone conduction device that uses the teeth, and it's designed to take the sound from outside. You wear a behind the ear device and it wirelessly sends a signal to this device that's attached to your teeth and vibrates the teeth to then stimulate the inner ear. And that's for different types of hearing loss. I mean, it would be for someone who has either single-sided deafness or hearing loss in one ear, or these other conductive or mixed hearing losses that we talked about. But I'm not...
And another, and again, for single-sided deafness, when Dr. Goddard showed the bone-anchored hearing aid that had the little snap-like thing on the back, and you put the processor on, there are accessories that you can actually use to plug into that for the telephone, and they're probably in the next 4 or 5 months, they're coming out with Bluetooth accessories for bone-anchored devices.
Let's hear a question from the left, something President Reagan told Dr. House he'd just soon not.
A sister of mine lost hearing in 1 ear a number of years ago. She's had a lot of treatment with audiology at University of Michigan, and they said nothing could be done, and that she could not have a cochlear implant because they would not do it unless it was both ears. Mm-hmm. Has that changed at all? Is there where you could have a single implant?
Yes, simple. We're working on it. We have an FDA study now, which has been approved for us to now begin to implant some patients who have single-sided deafness that would be a candidate for a cochlear implant. So your sister is a candidate probably in not too distant future. They're doing it in Europe. It's not approved. So what we have to do is we have to prove to the FDA that it's effective and safe. And once we've proved that, then it'll be opened up.
I think we have just some time limitations, so we'll take one more question from this side and one more question from the other side.
Hi, I'm Gretchen Anderson. My question is, does Medicare cover any of these things? What are the costs of, like the micro BTE or the invisible in the canal?
So I'll address that one because you're speaking about hearing aids, I'm assuming, right? Yes, okay.
Well, let me just say that some of the surgical devices are typically covered, but the...
Yeah, so I was going to say some of the medical stuff that we talked about is probably covered by Medicare. But I will say right now Medicare does not cover anything to do with hearing aids. Nothing.
Which is a problem, obviously.
Which is a problem. It never has. I don't know if it will, but without a question. Now, if you had other insurance, you could certainly check in to see if there's a benefit. But I realize most people, when we get a certain age, are going to have Medicare, and they don't cover hearing aids.
Well, what about the cost?
The cost... Yeah, in that, you remember when I had the slide that had the different levels of technology from a kind of a basic to the premier? They can range, obviously, depending where you go, but what affects the cost is how advanced the hearing aid is, not the size of the hearing aid. And they can range anywhere from about $1,200 per hearing aid all the way up to some very advanced hearing aids that are about $3,600 for each hearing aid. So again, depends on the technology level is what you're typically paying for. Medi-Cal is different, and that's correct, yes.
Did everybody hear the correction? Medi-Cal does pay
for one hearing aid,
for
not
one
two.
Hearing aid.
Only one.
Okay, our last question, please.
I'm Jack Crossley, and my question is about batteries. I notice a significant price difference. I use 312 batteries, and I think an awful lot of people do.
That's a common size, yes.
And they go from 25 cents a battery at Costco to $1 a battery from the hearing aid store. Any difference?
No, no difference at all.
Did everybody hear the question? Is there any difference? One's 25 cents, the other's $1. Is there any difference?
To buy in bulk.
Well, I want to thank our...
Get them on the internet.
Thank you very much. We're going to move into the next session. I have the privilege of introducing our first speaker, and I want to thank our panelists for a wonderful job.
Thank you.
Be safe. Thanks, Jim. The next session is focused on latest research, communication, and a very important, effective self-advocacy. And I'm going to introduce, and it's my privilege to do this, Mrs. Charlotte Shamadan. Charlotte happens to be a trustee of the House Research Institute, so I have to be very kind to her. The suggestion is, probably welcomed by many, is let's take a 5-minute bathroom break. But please, 5 minutes so we can move on and keep in touch.